If your doctor told you to take your calcium and vitamin D and go for a walk, that's a start. But for most postmenopausal women, whether on breast cancer treatment or not, that advice alone will not prevent fractures. The evidence on this is clear, and it is not what most women have been told. Here's what the evidence actually says. Calcium and vitamin D are essential for bone health. There is no debate about that whatsoever. Calcium is the primary mineral in bone. Your body needs adequate calcium intake to maintain bone density. The recommended daily intake for postmenopausal women is approximately 1,000 to 1,200 milligrams per day from combined food and supplement sources. Food sources first: dairy, leafy greens, fortified foods, with supplements only to fill the gaps. Vitamin D is critical because without it, your gut cannot absorb calcium properly. Even with perfect calcium intake, vitamin D deficiency means that calcium just passes straight through you. The recommended daily intake of vitamin D per the National Academy of Medicine, which the Menopause Society endorses, by the way, is 600 IU per day for women ages 51 to 70 and 800 IU per day for women over 70. These amounts are designed to maintain a serum concentration or level of 25-hydroxyvitamin D of at least 20 nanograms per ml, which is the target for the general population. However, for women on bone medications like denosumab or bisphosphonates, many bone specialists prefer a blood level of 30 or above because having enough vitamin D on board is critical to preventing dangerously low calcium levels when these drugs are started. The amount of supplement that you personally need to reach that level varies, which is exactly why your provider should check your actual vitamin D blood level before starting any bone medication, rather than just telling you to take a standard dose and hoping for the best. Healthcare providers, listen up. Vitamin D deficiency is extremely common in postmenopausal women and can worsen hypocalcemia, especially when starting anti-resorptive medications. Always check the 25-hydroxy vitamin D level before initiating therapy. Again, the minimum target is 20 nanograms per ml for the general population per the Menopause Society, but many clinicians prefer 30 nanograms per ml in patients about to start denosumab or zoledronate. Dose is based on the measured level. It is not a fixed number. And this is not a message only for women on aromatase inhibitors. For most postmenopausal women, calcium and vitamin D alone without additional bone protective medication when indicated are insufficient to prevent fractures. Multiple large randomized controlled trials, including the Women's Health Initiative, have shown that calcium and vitamin D supplementation alone do not significantly reduce fracture risk in postmenopausal women at elevated risk. The bone loss that comes with estrogen withdrawal at menopause is a universal biological event. It is not a side effect unique to cancer treatment. And for millions of women, it goes unrecognized and untreated until a fracture occurs. So calcium and vitamin D are necessary, but they are not sufficient. Think of them as the foundation. Without them, drugs work less well. But with them, you are not adequately protecting bones in the face of postmenopausal or AI-driven bone loss. What about exercise? Exercise is genuinely important for bone health, but not all exercise is equal, and some of the most common assumptions about which exercises help are actually wrong. Let's be precise about this because it matters. The exercises with the best evidence for preserving or building bone density fall into two categories. First, resistance and strength training, like lifting weights, using resistance bands, or working against your own body weight. This is the gold standard. Strength training places direct mechanical load on bone, stimulating osteoblasts, which are the bone building cells we talked about, and has the best evidence for increasing bone density, though the effect is largely site specific to the muscles and bones that are being worked. Second, impact activities, things like jumping, skipping, stair climbing, dancing, tennis, and even hiking. Those generate enough ground reaction force to signal bone to remodel and strengthen. Now, for the important corrections to what many people have been told. Walking is often listed as a weight bearing bone exercise, and technically, it does place some load on the skeleton, but the evidence shows that walking alone does not improve bone mass. At best, it can help limit further loss. The mechanical intensity simply is not high enough to drive meaningful bone formation. Brisk walking and hiking are better than a gentle stroll, but they are not a substitute for resistance training or impact exercise. Jogging and endurance running, a lot more complicated subject and actually concerning for postmenopausal women. So listen up here. While low to moderate jogging has some impact benefit, high volume endurance training has been associated in multiple studies with lower bone density, not higher. Long distance runners can have less bone mass than sprinters and even less than some sedentary individuals. The reasons include chronically elevated cortisol from high training volumes, low body weight, and critically for this audience, suppressed estrogen. In women with significantly low T scores or multiple risk factors, exercise is a support strategy, not a primary treatment. Postmenopausal women and women on aromatase inhibitors are already dealing with near zero estrogen levels. Adding high volume endurance running on top of that is not a bone protective strategy. The practical prescription for postmenopausal women and those on AI therapy is this: prioritize resistance training with progressive loading at least 2 days a week, and impact activities like dancing, stair climbing, or jumping if your fracture risk and physical condition allow this. And use brisk walking as a cardiovascular and general health tool, not as your primary bone protection strategy. The World Health Organization recommends at least 150 to 300 minutes of moderate intensity activity per week for adults, including muscle strengthening on 2 or more days a week. And for this population, those muscle straining days are the most important part of that prescription. But, and this is the critical message of this episode, even the best exercise program cannot reverse established osteoporosis or keep up with the rate of bone loss being driven by near zero estrogen in postmenopausal women. Exercise is essential support. It is not a substitute for medication when medication is indicated. The honest summary over here is calcium, vitamin D, and the right exercise are essential for every postmenopausal woman. But for women at elevated risk fracture, they are not sufficient on their own. For that, we need medication. And that is our next episode. In women with significantly low T scores or multiple risk factors, exercise is a support strategy, not a primary treatment. Think of it this way: calcium, vitamin D, and exercise are like wearing your seatbelt. They're absolutely necessary, but if the car is heading towards a cliff, you also need the brakes. For high risk women, such as those on aromatase inhibitors at real fracture risk, the breaks are anti resorptive medications. Coming up next, the drugs that protect your bones, how they work, how long you take them, and what side effects to watch for. See you soon.